Peritoneum, omentum, and mesentery. Generalized septic peritonitis. It's a life-threatening condition. Gross changes. Fibrin deposition leads to inflamed areas become opaque and adhere to form pyogenic membrane. Excess purulent exudate accumulates, at first paralytic ileus, later fibrinous adhesions leading to mechanical intestinal obstruction. Fate, it depends on the virulence of the organisms and efficiency of treatment, plus the body resistance. Etiology, causative organisms include Escherichia coli, bacteroids, pneumococci, aerobic and anaerobic streptococci. Sources of infection, local spread, direct entry, and blood spread. Local spread, the commonest route, infected organs as appendicitis, cholecystitis, or diverticulitis. Leaking organs such as perforated peptic ulcer, perforated typhoid ulcer, leaking anastomosis, ruptured gut or extravasated urine. Direct entry through operative or traumatic wound. Blood spread may occur in sepsemia and pyemia, which is rare. Pathology, fate, is divided into 4: resolution, localization, flaring up, and septic shock. Septic shock, multiple organ failure, MOF, and death. Resolution, the peritoneum has great resistance to infection. If source of infection is controlled or removed, peritonitis resolves. Localization, abscess formation. If complete resolution fails, pus localizes leads to abscess. Localization may occur whether by around the primary focus, as in acute appendicitis or cholecystitis, by adhesions of intestine and omentum around the inflamed organ, or in one of the anatomical compartments of the peritoneal cavity to form a remote abscess, such as subphrenic, iliac, or pelvic abscess. Flaring up, diffuse, generalized peritonitis. Predisposing factors include high virulence of the organisms. Sudden perforation of a hollow viscus leads to not allowing the defense mechanisms to localize the source of infection. Persistent source of infection. Stimulation of peristalsis by eating enemas or purgatives. Immunosuppression as in diabetes, AIDS, and patients receiving corticosteroids or chemotherapy. In children, because the greater omentum in small size and not well developed, this has an important role in localization. Primary peritonitis incidence, uncommon form of septic peritonitis which usually affects female children. Etiology, no apparent intraperitoneal pathology. Main organisms, pneumococci, streptococci. Route, enter the peritoneum through the fallopian tubes. Again, to the clinical picture of generalized septic peritonitis. Symptoms, pain. Character, dull aching, persistent pain, increases by movements or coughing. The site of maximum pain at the site of the original lesion. Symptoms of paralytic ileus, vomiting, at first gastric contents, then becomes bilious. In long-standing cases, the vomitus become feculent. Abdominal distension and absolute constipation. Signs, general and local. General, the patient looks distressed, toxic, lies still in bed, avoiding any movement. There is pyrexia and tachycardia. In neglected cases, it presents by sunken eyes, anxious look, which is called facies hypocratica, and clinical picture of septic shock. Local abdominal examination, by palpation, generalized tenderness, rebound tenderness, and rigidity. Auscultation, absent bowel sounds due to paralytic ileus. Investigations, laboratory, CBC, polymorphonuclear leukocytosis with shift to the left. Imaging, plain abdominal X-ray, showing paralytic ileus with distension of the small and large bowel. It may determine primary lesion, as with perforated peptic ulcer, air under diaphragm. Abdominal ultrasound or CT, it reveals free fluid in the peritoneal cavity. Guided peritoneal aspiration determines the nature of fluid and allows bacterial culture and sensitivity. Treatment, preoperative preparation, nasogastric tube to deflate stomach and bowels, prevent vomiting during induction of anesthesia. IV fluids as saline or Ringer's lactate to correct hypovolemia. Antibiotics, a combination of ampicillin and aminoglycoside with metronidazole, covers all aerobic and anaerobic organisms. It may be changed after results of pus culture and sensitivity. Analgesia, a Foley ester to check urine output and adequacy of fluid replacement. At first, the patient presents by clinical picture of the original cause as acute appendicitis or perforated duodenal ulcer. Later, when the condition is fully established, difficult to tell the original cause. The site of maximum tenderness and rigidity usually indicates the source of infection. The treatment of pus anywhere in the body is drainage. Acute generalized peritonitis is a surgical emergency. Drainage of the subcutaneous space is also useful as the wound is very likely to get infected. Operation: exploratory laparotomy done when general condition is satisfactory, general anesthesia, long midline incision, pus is sampled for culture and sensitivity and is suctioned out. Deal with primary lesion to stop further contamination. For example, a perforated appendix, it should be removed. A perforated peptic ulcer, it's closed by omental patch. Peritoneal toilet by copious irrigation with sterile saline. Peritoneal drainage may be done. The drain come out through separate stabs. And as Dr. Matary would say, افتح اغسل درنا عاجل. Localized septic peritonitis, intraperitoneal abscess. An intraperitoneal abscess, the defensive mechanisms successfully localize the source of infection. These protective mechanisms include omentum, abdominal policeman, matting of loops of bowel around the source of infection. The common sites of intraperitoneal abscesses are iliac fossa, pelvis, and subdiaphragmatic space. Pelvic abscess definition is a collection of pus in the rectovesical pouch or Douglas pouch. Causes: acute appendicitis, localization of resolving diffuse peritonitis, and finally pelvic inflammatory disease (PID) in females. Clinical picture: symptoms: general, hectic fever and toxemia, local, deep pelvic pain, diarrhea and tenesmus due to rectal irritation, burning micturition in frequency due to bladder irritation. If neglected, it bursts through the rectum or the vagina. Signs: DRE, direct rectal examination, fullness and tenderness in front of the rectum. Treatment: drainage according to the site of pointing. If in rectum, transrectal drainage. If in vagina, drains through the posterior fornix, and if in the suprapubic region, percutaneous ultrasound guided drainage. Iliac abscess, etiology: on the right side, acute appendicitis, perforated duodenal ulcer. The exudate trickles through the right paracolic gutter. On the left side, perforated diverticulitis and perforation of carcinoma of the sigmoid colon. On either side, spread from female genital organs and secondary to generalized peritonitis. Localization. Clinical picture: symptoms: general, hectic fever, local, iliac pain and vomiting. Signs: iliac tenderness and rigidity. Tender mass may be felt. Investigations: lab, CBC, polymorphic nuclear leukocytosis. Imaging, ultrasound examination. It determines the site and size of abscess. Permits, guided. Aspiration and drainage. Aspiration for bacterial culture and drainage as a form of treatment. Treatment: drainage of pus. This is the cornerstone of treatment, either by surgery or guided percutaneous placement of a catheter. Controlling the cause: in case of acutely inflamed appendix, not removed, an interval appendectomy after 6 months, it's much easier and safer. The use of effective antibiotics. Subphrenic abscess, etiology: residual pus collection following generalized peritonitis, perforated viscera as appendix, gallbladder or peptic ulcer. Anatomy of subphrenic space: the subphrenic region is a portion of the abdominal cavity which extends from above, diaphragm, below, transverse colon and mesocolon. The region is divided by the liver into suprahepatic compartment and infrahepatic compartment. The suprahepatic compartment is divided by the falciform ligament into right and left parts, and the infrahepatic compartment, the right infrahepatic space, hepatorenal pouch of Morrison, is the most dependent part of the abdomen when a person is lying down, the preferred site for pus to collect. Above and in front are liver and gallbladder. Below and behind are the upper pole of the right kidney, right adrenal gland, and the second part of the duodenum. Clinical picture of the subphrenic abscess: symptoms: general, fever and persistent hiccough. Local, may be totally absent, slight pain, site in the epigastrium, refer to the shoulder due to phrenic nerve irritation. Signs: general, hectic fever, tachycardia, severe toxemia with anorexia, vomiting and sweating. Local, inspection, impaired chest movement on the affected side. Palpation, tenderness may be present over the lower lips and intercostal spaces or below the costal margin. There may be swelling and rigidity of the upper abdomen. Auscultation, impaired air entry and crepitations over the lung base of the affected site. Investigations. Lab, CBC, polymorphonuclear nuclear leukocytosis with chest to the left. Imaging, plain chest X-ray, elevated fixed diaphragm, obliteration of the costophrenic space by minimal pleural effusion, gas under diaphragm or air fluid level when the cause is a perforated viscus or there is infection with gas-forming organisms. Abdominal ultrasound and CT localizes the abscess, allow guided aspiration for bacterial culture or guided drainage. Treatment, conservative treatment, indications, early cases, methods by antibiotics. Percutaneous aspiration, indications, failure of conservative treatment, method, placement of a percutaneous catheter under ultrasound or CT guidance, open drainage by surgery, sick path, and multilocular abscess. Subphrenic abscess is suspected if there is general manifestations of pus, but it cannot find the source, particularly after abdominal surgery with inflammation of an abdominal organ. Pus somewhere, pus nowhere else, and pus under diaphragm. Tuberculous peritonitis. Etiology. It's always secondary to tuberculous focus elsewhere, which reaches the peritoneum through direct spread and blood spread, and finally lymphatic spread. Lymphatic from pleura or bowel. Blood, pulmonary tuberculosis, direct spread, TB lymphadenitis, TB enteritis, and finally, which is the commonest cause, tuberculous salpingitis. Pathology. Ascetic type, caseous type, incested type, and adhesive type. Ascetic type, this is the commonest type. The peritoneum is studded with tubercles and there is copious amount of straw-colored ascites. The greater omentum is thickened, fibrosed, frequently rolled up, forming a sausage-shaped mass above the umbilicus. Caseous type, purulent form. It affects young females as a complication of TB salpingitis. The peritoneum is studded with tubercles and thickened. Multiple collections of caseous material are present among the adherent bowel and omentum. Cold abscess may form and may point to sinuses and fistulae. Encysted type, localized form of the ascetic type. The fluid is encysted by fibrous adhesions and coils of bowel. It produces an intra-abdominal cyst, may be mistaken for an ovarian and mesenteric cysts. Adhesive type, fibrous or plastic form, characterized by extensive peritoneal adhesions leading to intestinal obstruction. Clinical picture, type of the patient. It usually affects children and young adults of both sexes. Symptoms, recurrent attacks of abdominal pain, vomiting, or distension. Signs, general, TB toxemia, night fevers, night sweats, anorexia, and wasting. Local, palpation, the abdomen is filled dewy with multiple palpable swellings, maybe lymph nodes or omentum. Sausage-shaped mass filled above the umbilicus, rolled omentum. Tenderness may be present. Percussion, ascites is a common finding. PV may reveal tubo-ovarian mass. Investigations, laboratory CBC, may reveal anemia, lymphocytosis, and raised ESR. Tuberculin test, highly positive. Imaging, plain chest X-ray, abdominal ultrasound may reveal loculated or free ascites or multiple swellings due to caseous collections of pus among adherent loops of intestine. Instrumental, abdominal tapping, laparoscopy with biopsy, and exploration. Abdominal tapping indications performed in the ascetic type. The aspirated fluid is clear and straw-colored, specific gravity more than 1020, very rich in lymphocytes to demonstrate TB bacilli culture or PCR better and necessary. Laparoscopy with biopsy, the gold standard for diagnosis, direct visualization of the characteristic tubercles and permits biopsy, a solid proof of the diagnosis. Anti-TB drugs can be taken. Exploration, it's seldomly needed. It's difficult to detect TB bacilli by direct films. Treatment, medical. This is the main treatment. At least 2 anti-TB drugs, isonicotinic acid hydrazide and rimacetin, are prescribed for at least 1 year. Operation, rarely indicated, especially in intestinal obstruction. Ascites. Definition, pathological accumulation of fluid in the peritoneal cavity, can be recognized clinically when the amount of fluid is more than 1,500 milliliters. Etiology, general causes, generalized tendency for edema formation, liver diseases such as liver cirrhosis, cardiac diseases such as heart failure, renal diseases such as nephrotic syndrome, nutritional defects such as low serum albumin. Local causes, exudate, TB peritonitis, acute, miliary, or ascitic type. Malignant ascites, usually secondary to carcinoma of abdominal organs, chylous ascites, and pancreatic ascites. Rare causes, Meigs syndrome due to ovarian fibroma, and finally, pseudomyxoma peritonei. Differences between the main causes of ascites. We have cirrhotic ascites, malignant ascites, and tuberculous ascites. Age, cirrhotic, any age. Malignant, elderly, maybe young with ovarian cancer. Tuberculous, usually young. History, for the cirrhotic, jaundice or hematemesis. Malignant, short history, there may be symptoms of primary tumor. Tuberculous ascites, long history of low-grade fever, abdominal pain, and weight loss. General examination and abdominal examination. For the cirrhotic, general examination, features of liver insufficiency, and the abdominal examination, hepatomegaly and or splenomegaly. For malignant ascites, general examination, probably distant metastasis, abdominal examination, multiple hard abdominal masses may be palpable. For tuberculous ascites, general examination, low-grade fever and cachexia, abdominal examination, doughy mass may be palpable. Liver function test for the cirrhotic, poor, malignant, normal but may be impaired with liver metastasis, and tuberculous ascites, it's normal. Ultrasound, cirrhotic liver and splenomegaly in cirrhotic ascites, and in malignant ascites, abdominal masses may be detected. Tuberculous ascites, abdominal masses may be detected. Tapping, for cirrhotic ascites, transudate, specific gravity less than 1020. For malignant ascites, exudate, specific gravity more than 1020. Serosanguinous, cytology may show malignant cells. Tuberculous ascites, tapping shows straw-colored exudates, specific gravity more than 1020. Culture or PCR is diagnostic. Treatment, for the cirrhotic ascites, medical treatment, and peritoneal venous shunt with bad prognosis. For malignant ascites, tapping, local hyperthermic chemotherapy, very bad prognosis. Tuberculous ascites, anti-TB drugs, and with good prognosis. Peritoneal tumors, peritoneal carcinomatosis, pathology, origin, caused by implantation of secondaries on peritoneal surfaces. It's a terminal event in many cases of carcinoma of the stomach, colon, breast, ovary, and other abdominal organs. Gross picture, the peritoneum, both visceral and parietal, studded with malignant nodules. The peritoneal cavity contains ascitic fluid, which is usually blood-stained. Peritoneectomy entails excision of the visceral and parietal peritoneum plus omentum. Treatment, the condition used to be considered incurable and terminal. Recent introduction of combined excision of the primary tumor, peritoneectomy, and hyperthermic intraperitoneal chemotherapy has improved the 5-year survival. Pseudomyxoma peritonei, etiology, rupture of the pseudomucinous cyst of the ovary or rupture of mucoid carcinoma of the appendix. Pathology, abdomen is filled with yellow jelly-like material, low-grade inflammation occurs, fibrinous or fibrous adhesions. Clinical picture, abdominal examination showing distended abdomen without shifting dullness, multiple firm masses are palpable. Treatment, recent introduction of combined excision of the primary tumor, peritoneectomy, and hyperthermic intraperitoneal chemotherapy has partially improved the 5-year survival of this aggressive malignancy. Mesothelioma, primary neoplasm of the peritoneum, in contrast to the above-mentioned two tumors, it's also known to affect pleura, incidence, rare, cause, suspected to be caused by exposure to asbestos, types and presentation, either diffuse ascites leading to localized and bulky abdominal mass. Torsion of the omentum, clinical picture, sudden abdominal pain, abdomen is rigid and tender, the twisted omentum may be palpable. Treatment, excision of the strangulated omentum. Torsion of the omentum is predisposed to be by adhesions of the omentum to a hernia or old focus of infection. Usually diagnosis only after exploration. Mesenteric cysts, types, chylolymphatic cyst, interrogenous cyst, teratomatous dermoid cyst, and hydatid cyst. Teratomatous dermoid and hydatid cyst are treated by inoculation. Chylolymphatic cyst, this is the commonest. Etiology, retention cyst caused by obstruction of lymphatic drainage. Pathology, cyst is thin-walled, lined with endothelium, containing lymph, chyle. Its blood supply is separate from that of the related to intestinal loop. Treatment, inoculation, leaving the related intestine intact. Interrogenous cyst, cause, represents incompletely duplicated intestine. Pathology, thick-walled, lined with intestinal mucosa, containing mucus. Its blood supply derived from the same vessels of the related intestinal loop, and treatment by excision with resection and anastomosis of the related loop of intestine. Clinical picture, type of the patient more in children and young adults. Symptoms, pain, usually absent. Abdominal swelling or dyspepsia, usually the complaint. Signs, Tilo triad, the cyst is near the umbilicus. It moves across and not along the root of mesentery. The cyst is dull on percussion and there is a zone of resonance around and over it due to presence of loops of bowel surrounding in and in front of it. Large abdominal cysts, pancreatic pseudocyst in the upper abdomen, mesenteric cyst, mid-abdomen, characteristic mobility, ovarian cyst, pelvi-abdominal, and hydronephrosis extending to renal angle. Mesenteric lymphadenitis, acute non-specific mesenteric adenitis. Pathology, microscopically, the disease involves primarily ileocecal lymph nodes and they become enlarged, a small amount of clear serous fluid within the peritoneal cavity. Microscopically, the nodes show pattern of reactive hyperplasia, culture usually negative. The clinical features are close to those of acute appendicitis. It's not easy to differentiate the two conditions, and whenever in doubt, it's much safer to operate on the patient than to miss an inflamed appendix in a child. Incidence: one of the commonest causes of acute abdominal pain in children. Etiology: exact etiology is unknown but may follow viral respiratory infection. Clinical picture, type of the patient. It affects children, unusual after puberty. Symptoms: upper abdominal pain which localizes to the right side. Character: colicky and severe. Duration: lasting for a short time. There may be nausea, vomiting, malaise, anorexia, and fever. Signs: voluntary abdominal guarding but no rigidity. Abdominal tenderness marked along the line of mesentery and sometimes rebound tenderness. Direct rectal examination, tenderness may be elicited. Shifting tenderness. This is a valuable sign for differentiation from appendicitis. After lying the patient on the left side for a few minutes, the point of maximum tenderness shifts towards the midline. Then we have a comparison between acute appendicitis and non-specific mesenteric lymphadenitis. Acute appendicitis, the course of pain is continuous. The point of maximum tenderness is at McBurney's point. Rovthing sign is positive and shifting tenderness is absent. Non-specific mesenteric lymphadenitis is with present shifting tenderness, negative Rovthing's sign, and the point of maximum tenderness is above and medial to McBurney's point, with the course of pain periods of complete freedom of pain. Treatment: usually these patients are operated upon with provisional diagnosis of acute appendicitis. The mesentery is found congested and containing multiple soft lymph nodes. Appendectomy is performed and post-operative course is usually uneventful. Then we have tuberculous mesenteric adenitis or tabes mesenterica. Definition: childhood type of intestinal TB which is comparable to the primary complex of the lung but it's less common. Pathology: consists of small focus of in the distal ileum called Peyer's patches, huge enlargement of mesenteric nodes. The fate: the nodes may undergo whether healing by fibrosis and calcification or caseation occurring leading to mesenteric cold abscess, which is a cold calcified uncomplicated node which needs no treatment. Etiology: organism Mycobacterium tuberculosis. Root: ingestion of contaminated milk. Clinical picture: during activity, symptoms are general TB, toxemia, low-grade fever, sweating, wasting, and pallor. Local abdominal pain with vomiting and diarrhea. Signs: in acute cases, severe tenderness, rebound tenderness, and rigidity in the right iliac fossa, simulating appendicitis, or along the line of the mesentery. Firm irregular tender masses may be felt, which are the nodes. Investigations: lab, leukocyte count is normal, tuberculin test. If the test is negative, TB is excluded, and finally PCR. Imaging X-ray of the abdomen may show calcified nodes as mottled opacities arranged along the line of the small intestine mesentery. Treatment for active cases: anti-TB drugs. The retroperitoneal space is a portion of the body which is bounded anteriorly by posterior peritoneum, posteriorly by the spine and posterior abdominal wall muscles, superiorly by the 12th rib and attachments of the diaphragm, inferiorly extending to the pelvis. There are no anatomical barriers in this area, so pathological processes extend easily through it. Retroperitoneal tumors, renal and adrenal tumors, they are discussed in the urology, as we have explained. Retroperitoneal sarcoma, clinical picture. Symptoms: the patient may complain of vague abdominal pain if lesion infiltrates the colon, chronic large bowel obstruction, If the ureter is obstructed, renal pain, signs, fixed and hard abdominal mass, the size of the lesion outmatches its symptoms. Investigations, ultrasound and CT scan, they are very useful for diagnosis. CT scan accurately localizes the lesion, its size, and reveals infiltration of the adjacent structures. Treatment, the patient is explored for the possibility of resection. Unfortunately, most of the cases are unresectable, and all what we can do is take biopsy. Radiotherapy may offer some palliation. Retroperitoneal lipoma is more common in females, growing slowly and attaining a large size, prone to malignant transformation. And finally, retroperitoneal lymphoma. And this concludes the peritoneum.